Good afternoon, everyone. It's so wonderful to be here in person with a room full of people and with even more watching on the live stream. I'm Lloyd Minor, Dean of the Stanford School of Medicine, and it's been amazing to see this department come together. Doug mentioned a little bit about the history, but let me just give a brief synopsis. I've now been Dean of Medicine at Stanford for 10 years. It's hard to believe, it's flown by. And when I arrived, we had amazing epidemiologists, health policy experts, statisticians, and they were loosely grouped into a department known as the Department of Health Research and Policy. And yet there was a much broader group of people doing incredible scholarship, including Doug and his colleagues in the Center for Primary Care and Outcomes Research, which was a part of the Department of Medicine. And there were also people doing biostatistics and bioinformatics in other departments. And it was clear that we didn't quite have the right organizational structure. Now, none of us here at Stanford in particular, myself included, get hung up on organizational structure. The structure should follow function. In other words, you should have the organizational structure that enables people to do their very best work and to do it in a collaborative way. But it was clear that this structure wasn't quite getting there. And in particular, the first group that really wanted a departmental umbrella were the people in biomedical data science. And look, quantitation is heart and core to what Stanford is. And we had one of the, if not the first, bioinformatics PhD programs in the United States, dating back now well over 3 decades, which was an interdisciplinary program, meaning it didn't have an individual departmental home. And we had a desire to build and grow faculty in biostats, bioinformatics. So we created a department of biomedical data science. That department is thriving. It's recruited some absolutely amazing young people into the department, as well as provided a home and an umbrella for a group of people that had been in other departments around the School of Medicine and the university. And then the next department to be formed or sort of reshaped was the Department of Epidemiology and Population Health. Again, recognizing that Stanford does not have a school of public health. Epidemiology is core to, certainly we believe that before COVID. If we had any doubt before COVID, that doubt was removed because of COVID. Epidemiology and population health are core to the scholarship we need to be doing to provide the very best health to individuals and to populations. So we created the Department of Epidemiology and Population Health. And now, with the creation and the launching of the Department of Health Policy, which, as Doug said, officially occurred on September 1st of last year, I think we have the structures that enable the faculty and the students and the trainees to do the very best work in the collaborative way that so typifies and characterizes Stanford. And I'm grateful to the many, many people in this room watching the live stream and others that spent a lot of time thinking about what would be distinctive in the field of health policy and distinctive at Stanford in the creation of this Department of Health Policy within the School of Medicine. And in the end, it was the vision, the compelling vision that they came up with, and the endorsement of that vision by literally every single other school in the university that carried the day in the various processes, culminating with the Board of Trustees in the creation of this new department. And I want to thank Doug Owens for being the inaugural chair. Doug, of course, is a distinguished health policy expert, has been instrumental in analyzing from a very rigorous and quantitative point of view the efficacy and the applicability of various prevention screening mechanisms in our delivery system. And one of the themes I think that has been and is so compelling to me about the department is So much of what we do in medicine and healthcare today is based upon scant, paltry, in some cases non-existent evidence. And we do incredibly rigorous research that led to, for example, from the publishing of the sequence of the SARS-CoV-2 virus to FDA EUA for first-in-class RNA vaccines in 11 months. And the backbone of fundamental discovery research upon which that unprecedented speed in vaccine development was carried out, all of that was based upon very rigorous analysis and detailed, outstanding science. There's no reason why we can't, and we certainly should be, and we are, with our department and so many other collaborating departments at Stanford and around the country, doing the same sort of rigorous analysis of the healthcare we deliver. And that analysis then will inform the policies that others will make and hopefully implement to improve the value in our healthcare delivery system. So that's a little bit about the history behind the Department of Health Policy, and Doug, as he described in the video, its very close relationship with the Center for Health Policy and the Freeman Spogli Institute. Now, let me just say a few words about today's topic for this symposium, and that is the topic of health equity. A sad characteristic of health and healthcare in the United States is that it is challenged from the standpoint of equitable access and equitable delivery of care. We have, for those of us who can benefit and access it, the best sick care system in the world, unquestionably, with new fundamental advances in therapeutics for advanced acute and chronic diseases coming online every day. And yet, access to those services and to those cutting-edge therapies is incomplete and inconsistent across our country, and in particular, across different socioeconomic groups within our country. We knew that. We had firm evidence of that before COVID, but that stark reality became even more tragically apparent during COVID, and still to this day. And in a country that spends now close to 20% of gross domestic product on health care, we simply have to do better at providing access to that care and about ensuring that that care can be provided to anyone who needs it. Even more fundamentally, though, we have to provide the type of analysis and access to prevention and to confronting the other factors in addition to the health care we provide that are determinants of health. We've known for years that roughly, it depends upon the study, but roughly 70% of the determinants of health are social, behavioral, and environmental determinants of health. Many people in this room, Dr. Lisa Adams, many others have done pioneering research that establishes that beyond any doubt. Genetics and the medical care we receive account for maybe 20 to 30% of overall health outcomes. And yet, the amount of attention we focus, both in research and in resources in our delivery system, to prediction and prevention, the amount of attention that we focus to addressing the social, behavioral, and environmental determinants of health is far, far less than what we have devoted to developing the world's greatest sick care system. And I think the Department of Health Policy has a fundamental and incredibly important role at addressing these social and behavioral and environmental determinants from the standpoint of the scholarship of understanding what can be done, how do we re-envision our healthcare delivery system, and how can we create a more equitable healthcare environment in our country through the scholarship, through the training that's provided in this department. I know that's going to be illuminated this afternoon in the talks and in the work that you'll hear about. And certainly it's on the minds of Doug and all the colleagues in the department as they plan for a very exciting future for how this department is going to have impact in truly transformative ways. One of the things that I think is so distinctive about the department is the way it already is integrated within the broader Stanford ecosystem. And that truly is the secret sauce about being at Stanford, is that we don't have silos. We try to keep any boundaries or barriers between and among disciplines, between and among schools, as low as possible. We try to recruit great people, great faculty, great students, and then enable them to do their very best work in a collegial and collaborative environment. And that's what it's going to take to have the impact that we know we need to have in these vexing problems related to health equity. So thank you again for being here this afternoon. It's now my pleasure to invite Dr. Terrance Mays, Associate Dean for Strategy, Equity, and Inclusion, to share his vision for health equity at Stanford. Terrance?
Thank you, Dean Miner. And good afternoon, everyone. It's great to be here with you to share just a few words on not my vision, but Stanford Medicine's role in the future of health equity. But before I do that, I would also like to thank Doug Owens for his leadership and the faculty, staff, and students and trainees in the Department of Health Policy and across Stanford who work every day to advance health equity, to advance diversity, equity, and inclusion. In 2012, I joined Stanford Medicine as one of the DEI leaders here. In 2017, I left to pursue another opportunity, a brief stint that we don't talk about much. But in 2020, I made the decision to return. And I made the decision to return to Stanford because I firmly believe that Stanford Medicine is uniquely positioned to lead on health equity, to make a difference not only on a national stage, but within our community and the neighborhoods that surround us. After the horrific murder of George Floyd, I, like probably many of you, made a personal commitment to do social justice and health equity work with authenticity and in a way that would move the needle. I returned here to Stanford following a pledge made by Dean Miner and hospital CEOs David Entwistle and Paul King. And the pledge came on the heels of George Floyd's murder. And the pledge was simple. It said, Stanford Medicine will not be silent, and we will use our influence to build change, the change that we believe in. Enough is enough, they declared. And it was a promise made on behalf of the Stanford Medicine community that we will be part of the solution for creating a better society, a healthier and a more equitable society. And so following this pledge, Stanford Medicine launched the Commission on Justice and Equity. Hopefully many of you have heard about it and read about its work. The commission had a twofold charge to develop recommendations around creating a more equitable and inclusive Stanford Medicine community, as well as a strategy for establishing Stanford Medicine as a national leader for issues related to health equity and addressing racism as a public health crisis. Last year, the commission issued a set of bold recommendations that provide a holistic and enterprise-wide approach to dismantling structural racism, advancing diversity, equity, and inclusion, and addressing health disparities. These recommendations have shaped our vision around health equity, so that health equity is part of Stanford Medicine's core mission. And doing so by adding a health equity lens to all levels of decision-making here at Stanford, by ensuring culturally informed and equitable care across our health system, and doing so with informed data and standards. And by expanding and building trust in local communities, particularly local communities of color, and doing so through funded partnerships, through scholarships, and also first by simply listening. You will hear more today and in the days ahead about some of the important health equity work, health equity initiatives here at Stanford and at Stanford Medicine. Work that has come since and also well before the Commission on Justice and Equity. And I encourage you to learn more about these efforts and also to get involved. I also encourage you to read the Commission report, which has been made publicly available online. I am encouraged by seeing all of you today, knowing that this is our collective work, that we are in this together. You know, there's an African proverb that says, if you want to walk fast, walk alone, right? If you want to walk further, walk with others. And I want us to imagine a nation in which health outcomes are not determined by a zip code. Okay? Imagine healthcare that treats every single patient with the dignity and the respect that their humanity calls for. This is our time. This is the time, I firmly believe, to reimagine our health equity and our justice, equity, diversity, and inclusion efforts, to reimagine them and deliver them with creativity, with ingenuity, and with humility. Thank you.